We have a presentation by Professor Arun Jain, Look No Further, Conjunctival Pedicle Graft to the Rescue in Peripheral Perforations.
So thank you all the people on the dais for having me part of this program. So we were talking about the cost factor. So here is a procedure which has minimal cost involved. The cost it involves is only a suture, 10 or nylon suture. Rest of things are, you may not have everything available in emergency theater like a glue or a donor tissue. So what to do when you are faced with this perforation in an emergency situation where nothing is available except suture. So I will be emphasizing the conjunctival pedicle graft in the management of corneal perforation, especially the limbal sparing, because we don't want to leave behind a limbal stem cell deficiency. And the indications already has been highlighted by the previous speaker. These are the common causes of corneal thickening and perforations. The commoner ones are after the bacterial ulceration or dry eyes, neurotrophic keratitis, or collagen vascular disorder. And all of us are familiar with the medical management of the disease. Once the medical management fails, the persistent corneal ulceration doesn't respond to our conservative therapy. So various alternatives which has already been highlighted in the form of either fibrin or cyanoacrylate glue or amniotic membrane or patch graft, lamellar or PK, all are available to us, but I will again be confining myself to the limbal sparing conjunctival graft. The reference of these conjunctival graft goes way back to more than a century when Beers described conjunctival flaps in ophthalmic surgery. And then again the reference was made by Green J in 1927, and first time in 1958 Gunderson described the classical Gunderson flap based on the reported in archives of ophthalmology, and 11 years later he published around 31 cases of corneal thinning or perforation because of the various reasons by doing a Gunderson flap, and these were the indications for doing Gunderson flap in those cases. And with the progress of microsurgical technique aided by very good microscopes and fine surgical tools, I think selective penetrated conjunctival flaps cured in place by fine suture tailored to cover area of the diseased cornea. Chronic ulceration with or without corneal perforation is a good technique and may be performed in an outpatient setting, and postoperative recovery is quite rapid. And this paper in 2003 in Archives of Ophthalmology, again by Khodadost et al., they described management of these corneal perforations by conjunctival flap, but they didn't do limbal sparing pedicle conjunctival flaps. In this, half of the 11 cases had a perforation in these cases. So the objective of surgical management, as we all know, is the preservation of corneal and globe integrity as far as possible, and minimizing lesions incompatible with functional vision, and replacement of lost corneal tissue, and increasing the blood supply to the healing cornea. So, I think this is, and preventing any localized limbal stem cell deficiency which may be induced by dissection of conjunctival pedicle flap should also be avoided. So we did this limbal sparing conjunctival pedicle flap in 21 patients with corneal ulceration with or without perforation. 2 cases had corneal foreign body induced keratitis with perforation. 3 cases had post-chemical burn. 1 case of post-keratoplasty. 2 had corneal trauma. 5 had corneal non-infectious ulcerative keratitis. 2 had neurotrophic. So these are the indications in our cases of 21 cases. So this is one case of post-trauma which was badly sutured outside, and you can see the necrotic tissue. The chamber was flat and leaking. The person outside had already done a CI. So after removing the sutures which were very bad 80 silk and removing the necrotic tissue, we fashioned a pedicle flap. You can see we have spared the limbus and injecting the saline or xylocaine with the adrenaline. Make a very thin flap, as thin as possible. But if the corneal thinning is too much, then you can include tenon also along with this, and then suture it. So this part is attached. You make a oblique this thing so that there is no folding of the conjunctiva at that point. So this is what post-op day 1, and over a period of time, patient healed like this. After 1 year, I did a cataract surgery also with very good 6/9 result in this case. There's another case who had a peripheral corneal ulcer which was not amenable to medical treatment, and we did again a pedicle flap with a good result, 20/40 vision unaided. And this was another case who had uh, corneal infiltration with the foreign body. Once the foreign body was removed, it started leaking. So because it was infected and there was a speck of a satellite lesion also, we thought of doing a patch graft, but then we thought we will have to include this area also. Then I went ahead to do though this was small perforation, so I went ahead with the pedicle conjunctival graft. So this is the healing, though there is a little incarceration of the iris at that place. And this is a post burn. This was a grade 4 chemical burn. We put a glued on contact lens. Once the lens fell off, there was a persistent epithelial defect. So here we did a very thick conjunctiva and tenon, included a racket graft, and the persistent epithelial defect healed, and later on we referred the patient for keratoprosthesis. This is a very young child, 7-year-old male, had a corneal fallen body with again infiltrate. We tried to glue it 3 times, but there's a child, every time he'll rub and come back again with the perforation. So again we did a pedicle conjunctival graft which healed over a period of time, again sparing the pupillary axis, and a good result. So we, out of 21 patients, we had 5 had a corneal perforation. All of the patients had a stable pedicle graft. In one patient, slight graft retraction occurred on 5th day, which was resutured, and corneal ulcer healed in all cases. Globe integrity was preserved in all patients. None of the patients developed glaucoma, and none of the patients required patch graft or therapeutic penetrating keratoplasty. So to conclude, conjunctival pedicle graft is an appropriate procedure to manage corneal perforation and impending corneal perforation where donor material is not available and transplantation of such tissue is not suitable. The technique is performed easily, can aid in the healing of the area of thinning that threaten perforation by providing a vascular pedicle, and limbal sparing flap in presence of healthy limbus in addition helps prevent conjunctivalization of the cornea and therefore gives good anatomical as well as visual outcome. Thank you very much.
Thank you very much. Can I just ask one question, that when you make the pedicle, the rest of that area, you suture it or you just let it to heal on its own? The disconnected area.
Yes, or you can apply 1 or 2 suture to cover that area.
Just to cover it.
So that healing happens much faster and inflammation also is less. But then again, if you have a glue, you can pinch it also, but then again the cost factor will come.
Yeah, that is true. Thank you.
Yeah.